Hi, I'd like to welcome everyone to this session. I apologize about the room situation. We have no control over how the rooms are assigned. I understand there's extra seating in 208 as well. So welcome to Workshop 07, Best Abstracts in GI and Hepatology. My name is Linda Cummings. I'm an adult gastroenterologist at University Hospitals in Cleveland. And I'm joined by Dr. Meg Sauté, who's at University of Texas Southwestern Children's. She's a pediatric gastroenterologist. These are our disclosures. And during this session, we're going to highlight some cutting-edge research in GI and liver within cystic fibrosis. We're going to focus on some common CF-related GI and liver conditions. So we're going to look at potential mechanisms or therapies for GI complications in individuals with CF or CFTR variants, and evaluate the effects of CFTR modulator therapy on GI or liver complications of CF. And these are our objectives here, which kind of touch on the different abstracts that we've selected. We did attempt to get kind of a broad spectrum within peds, adult, GI, liver, and including some basic research, which is the second objective. Each speaker will speak for 15 minutes, and then we will allow 8 minutes after each one for questions and answers. You can either come up to the microphone for your questions, or you can use the Q&A section within the app. And I'd like to acknowledge Tanya Gonska, who was supposed to be my co-chair, but unfortunately was not able to make it, and Dr. Sauté graciously stepped in. And I'll let Dr. Sauté introduce the first speaker.
All right, so our first speaker is Dr. Drusi Borowitz, Emeritus Professor of Clinical Pediatrics at SUNY Buffalo, and she's going to be presenting her abstract evidence of protease dose response in a phase 1 trial of ANG003, a non-porcine pancreatic enzyme replacement therapy.
Thank you. I want to acknowledge that Dr. Michael Wilshansky here said, GI, this should be in Fenway Stadium, you know, it's like Fenway Park, excuse me. So I want to thank the moderators. Tanya, if you are watching, I hope you're doing okay. And I'm going to present this abstract, evidence of a protease dose response in a phase 1 trial of ANG003, which is a non-porcine pancreatic enzyme replacement therapy. And I'm doing this on behalf of the other authors of the abstract, our scientific collaborators, and I want to thank all the PIs, coordinators, and subjects who participated in this study. So these are my disclosures. I do have some conflicts of interest here. I am a member of the board of directors of Anagram Therapeutics, which is developing this drug, and I'm also a paid member of their scientific advisory committee. But I have also been in CF care for many, many years, and during that time working to understand pancreatic enzyme replacement therapy. And I really hope that for people with CF, we can advance this therapy, which is essentially unchanged over 70 years. So historically, fat absorption has been the focus of CF nutritional care, and lipase acts on triglycerides to break fatty acids off the glycerol backbone. And as part of this phase 1 study, we developed a measure to understand the activity of lipase by doing a blood test. And we have been able to show for the first time true dose response. I highly encourage you to go to Dr. Meg Sauté's presentation on the primary results of this phase 1 study, which are going to be at tomorrow's workshop 24 at 10:15 a.m., or see poster 670. Exploration of amylase activity was one of the secondary endpoints, and those results are in poster 671. And I'm going to talk about another of the secondary endpoints, which is protease activity. So in the post-modulator period, digestion and absorption of fat remains important. But
hey, Drusi, sorry.
Yes. I'm encouraging you to go see the primary outcome tomorrow. at 10:15. There are two secondary endpoints in this phase 1 study. One of them is amylase activity, and you can see that in the poster. And I'm going to talk about the other secondary endpoint, which is looking at protease activity. So, okay, let's just move forward. So dietary proteins are broken down into amino acids and oligopeptides, and this forms the basis of this secondary outcome measure. And I think what I missed saying is that in this era of ETI, although we've been thinking about fat absorption all the time, we really have the opportunity to think about quality of the diet, other nutrients, and so that's the focus today. So free amino acids and oligopeptides are absorbed differently from the GI tract, and they have different functions. Most dietary protein appears in the blood as oligopeptides. So single amino acids are absorbed by specific carriers. They may be used by gut bacteria for energy, and glutamate is used by enterocytes as an energy source. There are specific oligopeptide transporters on the mucosal surface, such as the PEP-T1 hydrogen-linked cotransporter. And that enables di- and tripeptides to be absorbed from the gut lumen into the blood. There are thousands of structurally different oligopeptides, and this diversity enables them to have complex physiologic functions, and they may help with prevention of some chronic diseases. So blood from the digestive capillaries flows through the portal vein into the liver. The pool of free amino acids is fairly stable, so you can't tell if a given dietary amino acid that appears in the blood unless you use a radio label to track it along. And so when animals are given a high protein load and you measure what's going on in their blood, there isn't a balance between the intake of amino acids and free amino acids in the blood. So that difference is likely made up of oligopeptides. So we hypothesized that measuring plasma oligopeptides would be a tool to determine the optimal dose of pancreatic protease for people with exocrine pancreatic insufficiency. So pigs and humans have different diets, and thus the secretion of digestive enzymes is not the same. Porcine pancreatic enzymes are life-sustaining drugs, so I don't want to diss them. But on the other hand, pigs have a different proportion of lipase to protease to amylase than humans do if you stimulate their pancreas with cholecystokinin. So if you look at this, so pancreatin was the first extract. An attempt to decrease the amount of protease was done by creating pancrelipase, which is what's in porcine pancreatic enzymes, most of them in the United States. And we don't really know what caused fibrosing colonopathy. As you know, we measure PERT, pancreatic enzyme replacement therapy, in lipase units, so nobody really paid any attention to the protease units, but it's likely those were very high as well. So the development of a sensitive measure to study protease activity can aid in the design of the rational design of a pancreatic enzyme replacement therapy for people with EPI, so that we give enough protease but not too much. So here's the design of the phase 1 study of ANG003, a broad spectrum PERT of microbially derived lipase, protease, and amylase. So rather than measure malabsorbed nutrients in the stool, we developed blood-based pharmacokinetic-like tests to measure absorbed nutrients in the blood after a specific substrate was given in the context of a mixed meal. So this is what we call a SACT, a substrate absorption challenge test. And during this first SACT period, no enzyme was given. And during the second SACT period, subjects ingested this combination of lipase, protease, and amylase simultaneously with the meal, and we studied different dose combinations. And that was done in parallel. So the dose combinations were taken with a mixed meal and specific substrates. I will say a lot of the work that's been done on absorption of proteins is done either with liquid or specified amino acid mixtures, and so this is more physiologic. So to study the protease activity, the substrate challenge was a meal bar that contained 10 grams of intact whey, which is a rapidly absorbed protein. There were an additional 28 grams of protein in the breakfast meal. So during the second SACT period, the 3 enzymes were delivered simultaneously but in separate mini tablets so that the dose response of each of the 3 components could be assessed independently. So the protease is derived from aspergillus and is naturally acid resistant. And although there were 4 dose levels of lipase, which was the primary endpoint, there were only 3 dose levels of protease, and so and amylase as well. So I'm going to combine those, so there are only three groups here. So others have shown that humans absorb peptides by identifying specific individual oligopeptides. However, there are an estimated 400 dipeptides and 8,000 tripeptides present after hydrolysis of dietary protein. So detection of each specific oligopeptide is really problematic. So in this diagram of a dipeptide, you can see that one nitrogen is hidden, and that's until that bond is hydrolyzed. If this were a tripeptide, there would be 2 nitrogens that would be hidden. So we use ninhydrin, which is widely used to analyze and characterize the nitrogen in amino acids, peptides, and proteins, and developed a high throughput method to detect all absorbed nitrogen in amine groups as a whole, and then after hydrolysis to break all the peptide bonds and release all of the amine groups. In a first step that's not shown here, we used a 10 kilodalton filter to remove very large plasma proteins such as albumin and fibrinogen before the plasma was processed. So here's some results. The demographics of the dosed subjects in phase 1 is not different from the general adult CF population. This was phase 1, it was all adults. These were fairly well-nourished subjects with a mean BMI of 24.3. 94% of the subjects were on modulators and were taking about 5 capsules of PERT per meal and 3 per snack, or 20 per day on average. We verified that 100% of the subjects had EPI and all had a fecal elastase of less than 100 micrograms per gram of stool. So as you can see, modulators in this group don't change pancreatic function. So there's a full description of the AEs in poster 614. So as I mentioned, previous work on absorption of proteins has almost always been done with liquid meals of defined amino acids or analysis of specific oligopeptides, and has not represented the full range of absorbed peptides. So the graphs here indicate the change in total amino acid equivalents on the y-axis, which if you were looking at the method slide, you saw represents the peptide-derived amino acid equivalent. So this is essentially the peptides that are absorbed after the meal. The time points on the x-axis, which are a little hard to see, are 1, 2, 4, and 6 hours. So as a reminder, day 1 is the whey sacked without any PERT supplementation, and day 5 is the data on the whey sacked with successively higher doses of protease, and in the context of all 3 enzymes. So this is the data just for the protease. So there's a trend to a higher change in the peptide-derived amino acid equivalent uptake, the peptide uptake, with successively higher protease doses, although the sample size is small. However, this is encouraging data, and we'll continue to explore use of the method for evaluating amino acid and peptide uptake in a planned phase 2 trial of ANG003, which would include a larger number of subjects. And again, the primary outcome is the lipase, which I'm telling you should just go see that abstract tomorrow. A strength of our method is that these responses are in the context of a mixed meal and in the context of all 3 enzymes, so mimicking what happens when people actually eat in the real world. So although this data is in EPI pigs and not humans, this is a comparison of the 50 and 75 milligram ANG003 protease doses to pancrelipase. This data has not yet been published and is kindly shared by Dr. Piranowska, who I saw sitting there, and her colleagues. The amount of protease in pancrelipase is variable since it's a biologic extract. It's measured in units, and units in the United States are not the same thing as units in Europe or elsewhere. This is why moving to milligrams, a milligram is a milligram everywhere around the world. But if you try to extrapolate how many milligrams of protease, there's about 200 milligrams of protease that was given here. And as you can see, in this experiment, administration of the 75 milligrams dose of aspergillus protease led to a significantly higher area under the curve at 6 hours and the Cmax compared to approximately 200 milligrams of pancrelipase protease. So porcine pancrelipase would be expected to be the optimal protease for pigs. This is a pig model. So I think these results are impressive. So in conclusion, this was a pilot study for the meninhydrin method. The transfer of the pig method to human blood, honestly, was a little challenging, and a study with more subjects and enhanced method sensitivity may allow this method to be a useful tool in clinical research and perhaps in patient care as well. These data are useful to inform the protease content for future studies and help guide a planned ANG003 phase 2 trial. The protease dose in ANG003 will be lower than it is in pancrelipase. And developing ways to measure optimal protein digestion and absorption remains important in this era of new nutritional goals for people with CF. So thank you.
Yes, I think we will modify the time for questions and answers to 5 minutes due to the delay from switching rooms. I don't see any questions in the app. You're welcome to come up to one of the microphones if you have a question.
No one has any questions, and I think it's probably because this was like a new area for me too. I mean, I really have not thought much about protein absorption, and I do really think we are at this change moment in history for people with CF. And so thinking about all of the nutrients and absorption and not just focusing on fat is an important part of moving forward. I said, oh, good. I was just trying to have a little delay until somebody came up with a question.
Thank you. Thank you for vamping. Jonathan Raymond from Vancouver. Is there any evidence that some of these serum markers are associated with lean body mass or imaging indices of nutrition or anything else like that?
Yeah. Do you work for the FDA? Because, of course, what they want is a clinical endpoint. So this was a single dose. This is a phase 1 trial, phase 1 just kind of exploring, tolerability, toxicity, some dose ranging, so a single dose. But absolutely, that's one of the things that we need to know moving forward. And, I think there are some interesting studies going on looking at muscle strength, body composition, things that might give you an idea about protein absorption. And, clearly growth is a big factor in looking for a relevant clinical outcome.
Yeah. And I think there's a big appeal to this kind of outcome measure rather than in a PERT trial, rather than making people stop to see how much fecal fat there is. That's a very unappealing trial for people to participate in.
Yeah, I think, the world has changed. And so in thinking about a phase 2 trial, it's like, what is doable? Of course, if you can't recruit subjects, you can't move forward. And we really hope this can move forward. I mean, you never know. We will see. But, you got to generate the data.
Thank you.
Just a quick cautionary point of using fecal pancreatic elastase as a marker for exocrine pancreatic insufficiency. Michelle Lewis from Mayo Clinic. We found in the adult gastroenterology world an incredibly high rate of false positives with using fecal pancreatic elastase test. We're seeing it in all of our patients with Crohn's disease, small intestine bacterial overgrowth, diarrhea from any cause, celiac. So in patients with cystic fibrosis, you can definitely have more than one cause of diarrhea or loose stools. So just maybe a plea to include other means of identifying these patients other than just a fecal pancreatic elastase.
Yeah, what you mention is there are, we think of primary pancreatic insufficiency in CF, but there absolutely are secondary causes of pancreatic insufficiency. So anything that affects the mucosa and it's signaling to the pancreas to tell it to release enzymes, will cause pancreatic insufficiency. Celiac disease, radiation enteritis, all sorts of things will cause a falsely, well, it's not a falsely low because there is secondary pancreatic insufficiency, but it's not primary pancreatic insufficiency. So that's a good point. All right, thank you. I think we're on time. All right.
Okay, we're going to welcome our next speaker, Dr. Gila Ginsburg. She's a pediatric GI fellow at the Medical College of Wisconsin, and she will be presenting her abstract, The Impact of CFTR Modulator Therapy on Acute Pancreatitis Frequency in Children with Acute or Recurrent Pancreatitis, a report from Inspire 2.
Good morning, everyone. I hope everybody enjoyed our field trip downstairs. In the interest of time, I will try and go through my presentation and leave enough time for questions, but also help us make up some time. I just want to thank the session moderators for inviting me to speak, and I'm really honored to be able to present our research on behalf of myself and all of our co-authors and collaborators. I have no financial disclosures. However, I am funded by the Cystic Fibrosis Foundation and want to thank them for my second year clinical fellowship award, which allowed me the time to devote to this project. So a lot of this is going to be kind of what we've discovered over the last few years, but that CFTR modulators have really changed the landscape of cystic fibrosis. We all know that they improve patient survivability. We're all very familiar with this graph that we're seeing here on the right, that they improve lung function, they decrease respiratory exacerbations. But what do they do to the GI tract? What do they do to the pancreas? We heard a little bit this morning at physician grand rounds that they're suspected that they perhaps improve the function, especially if we're starting them earlier. But we really don't know, and it's really a field of interest across the world. When we're looking at pancreatitis we heard a little bit this morning about acute pancreatitis in our physician grand rounds and defined it. But really what acute pancreatitis is where you have pancreatic enzymes that normally exit the pancreas into the digestive tract to help with digestion, get stuck within the pancreas and cause inflammation. And that results in the characteristic abdominal pain that we see, which is epigastric or periumbilical that typically radiates to the back. And in pediatrics as well as adults, we diagnose this using two of the following three criteria, where you have an elevated amylase or lipase that's greater than 3 times the upper limit of normal, characteristic abdominal pain, which is typically epigastric or periumbilical, that sometimes radiates to the back, and then compatible imaging findings, whether that's MRI, CT, or ultrasound, which is most commonly the modality we use in pediatrics. And typically in children, acute pancreatitis is most often minor and self-limited. However, we certainly have times where it is severe or progresses to a more chronic state. And so when we start to get recurrent episodes of acute pancreatitis, we are entering the realm of acute recurrent pancreatitis, which is exactly what it sounds like. You have more than 2 episodes or 2 or more episodes of acute pancreatitis separated in time by either complete resolution of symptoms or amylase and lipase that's going completely normal between those episodes. And as you can imagine, the more hits the pancreas takes, the more time you have acute pancreatitis, the more damage that occurs. Eventually, you can have scarring, fibrosis of the pancreas that can lead to chronic pancreatitis. And at this time, you're seeing now irreversible changes in the pancreas accompanied with either chronic abdominal pain, typically, again, in that periumbilical and epigastric region, either exocrine pancreatic insufficiency or endocrine pancreatic insufficiency manifesting as prediabetes or diabetes. And if you have a biopsy available, you'll see histology consistent with chronic pancreatitis, such as fibrosis and calcifications. So we know that in patients that have pancreatic sufficient cystic fibrosis, they are at increased risk of developing pancreatitis. And we think in part this is because there's stasis of the enzymes within the ducts of the pancreas. However, we also know that just carrying a CFTR variant, a single variant, will significantly increase your risk for pancreatitis. And so if we look at this study over here, this study looks at patients who are on CFTR modulators with cystic fibrosis who had pancreatic insufficiency. And you can see that they have quite a significant amount of acute pancreatitis attacks. Each one of those black dots represents an acute pancreatitis attack. But what's very interesting about these patients is they start a CFTR modulator, which is right over here, and then suddenly they have no further acute pancreatitis attacks. And so we were interested what this manifestation was going to be in children. So we utilized looking at the International Study Group of Pancreatitis, a pediatric pancreatitis in search for a cure called INSPIRE. And this is an international consortium of 25 pediatrics worldwide that's been collecting data from 2009 until current, it's a prospective database that collects a plethora of data on pancreatitis. It collects information on risk factors, natural history, detailed information on each and every acute pancreatitis attack, outcomes, and sequelae. And it is the largest pediatric database on acute, recurrent, and chronic pancreatitis. So we wanted to look at, in children with acute, recurrent, or chronic pancreatitis with at least one CFTR variant, did the modulators have an effect on acute pancreatitis? What was it going to do to the frequency? And our aim specifically was to compare this across each patient. So looking at each individual patient, did they start modulator therapy and their frequency of acute pancreatitis attacks go down? So this was performed using a multi-center retrospective cohort study using the INSPIRE consortium. And our inclusion criteria was any child less than equal to 18 that at their time of enrollment into INSPIRE, they either had to have acute, recurrent, or chronic pancreatitis and have at least one CFTR variant. And they had to have received a CFTR modulator during the data collection period. So it was either because they had cystic fibrosis and so they were receiving it in routine care through their CF team, and some of our patients received them off-label for treatment of acute, recurrent, or chronic pancreatitis. And then we also had to have sufficient enrollment within INSPIRE to be able to compare them. We took the patients that we had and divided them into two groups. Those that had a cystic fibrosis diagnosis, which in our study we defined as having two CF-causing genes and having a sweat chloride that was greater than or equal to 60 within this CF realm, and those that did not have cystic fibrosis, so anyone who did not meet the criteria for a CF diagnosis. And we looked at the acute pancreatitis attacks before and on CFTR modulators, looking at two things specifically, the absolute frequency, so what was their number before, what was their number afterwards, and their incidence density. So in the INSPIRE consortium, which has greater than 1,000 patients, we identified 22 patients that met our inclusion criteria. Their mean age of enrollment was 11, so they really represented pediatrics. 59% of them were male. 50% of them had a CF diagnosis and 50% of them did not. 64% of them had acute recurrent pancreatitis. And all previous studies in this realm have really been in pancreatic sufficient patients. So it's not surprising that the majority of our patients did have pancreatic sufficiency. However, 18% of them were insufficient. And this is a completely novel patient population. And then 23% of them did not have available fecal elastase, so we don't know that what their pancreatic status is. When we looked at which CFTR modulators our patients were on, 50% of them were on elexacaftor, tezacaftor, ivacaftor, including every patient with a CFTR single CFTR variant. And then 32% of them were on ivacaftor, 14% were on tezacaftor and ivacaftor, and 4% were on lumacaftor, ivacaftor. So this is similar to the chart that I showed you earlier on in the presentation, again, showing each and every individual patient with each one of those red dots representing acute pancreatitis. So if we look at, for example, this patient over here, patient number 7, we can see that this patient on this side of the red line is before the start of CFTR modulators. And this is a patient that's a CFTR carrier but does not have cystic fibrosis. And they had 3 attacks of pancreatitis in the 2 years prior to the start of modulator therapy. And once they start modulator therapy, they only have a single pancreatitis attack recorded. And similarly, we see that in cystic fibrosis patients, for example, this patient over here had 3 episodes before they started CFTR modulators and then started a modulator, and then after that had no documented cases of acute pancreatitis. When we looked at the total number of frequency, Each patient had a different follow-up period, so we couldn't make that direct comparison. So instead, we compared incidence density, which is the episodes of acute pancreatitis per person year. And you can see in the pre-CFTR modulator time era in both groups, the incidence density was 1.17. And then on CFTR modulators, we saw a 90% decrease to 0.18, which was significant with a p-value of less than 0.001. When we looked at sweat chloride values, and we looked at them in our CF group and our non-CF group, not surprising, those in the CF group had a sweat chloride of 81.3, which is consistent with a cystic fibrosis diagnosis. And those in our non-CF group were sitting at about 32.4, which in line with current literature is where we would expect CFTR carriers to be sitting. And we only had follow-up sweat chloride values in those patients with cystic fibrosis in 5 of those patients. And so you can see once they started the modulator therapy, it dropped to 38.25, which again is consistent with current literature on CFTR modulators. This is specifically looking at those 5 patients with cystic fibrosis who were on modulator therapy. And you can see they all dropped from a CF diagnostic realm down into an almost normal or intermediate range. So in conclusion, in the INSPIRE-2 cohort, CFTR modulators significantly decreased the incidence density of acute pancreatitis in both CF patients and non-CF patients. It is the largest pediatric study to date on CFTR modulators therapy in pancreatitis, and it suggests that CFTR modulators may be an effective treatment for patients with recurrent and chronic pancreatitis. I think there's a lot of future directions that we can go with this. This is certainly almost a pilot study to suggest the effects of CFTR modulators, and certainly longer-term follow-up is required in these patients to really evaluate what is this going to look like 5 years down the line, 10 years down the line, but also compare things such as pancreatic severity, complications of pancreatitis, long-term sequelae such as diabetes. And also evaluate which type of CFTR modulator is the most efficacious in decreasing pancreatitis episodes and affecting severity. And in line with this, we propose a clinical trial of CFTR modulators in children with acute recurrent and chronic pancreatitis with a single CFTR variant to evaluate their efficacy and safety. I want to acknowledge the fantastic team that's behind me and has helped me along the way, including the CF team at Children's Wisconsin, including Dr. Antos, all my co-authors, including Dr. Mark, Dr. Wolchansky, Dr. Chug, Dr. Uch, Dr. Lowe, the INSPIRE team, the CPDPC, as well as the Cystic Fibrosis Foundation. And I'm happy to take any questions.
We're actually running on schedule, so we will allow 8 minutes for questions.
And also, we're going to encourage you, if you are in this room, to use the microphone because there seems to be a lag on the questions that are coming in to the app.
So Camille Air from UNC Chapel Hill. I had a question in the reverse situation. If the patients were unable to take their treatment, had to stop CFTR modulators, do they have an increased odds of developing acute pancreatitis?
That's a fantastic question.
Can you repeat the question?
Yeah. For those that couldn't hear, in those patients who were taking CFTR modulators and had to stop for one reason or another, was there a rebound increase in acute pancreatitis? We didn't have the long-term follow-up to be able to analyze that, but I think it's an excellent question.
Hello, Vivek Shenoy, I'm Pete's GI at Emory University. So wonderful talk. And wanted to ask for those patients who were non-CF. We don't have sweat chlorides when they were put on the modulators itself, but I wonder if there's actually if you'd observe a decrease and if there's any benefit to bringing your CFTR function to like a supramaximal level. For those patients, or even if that could be extended to patients who don't actually have CF but have acute recurrent or chronic pancreatitis.
And again, an excellent question. We didn't have any follow-up sweat chlorides available in those patients that were just CFTR carriers, so I can't comment one way or the other, but certainly something that is being actively collected and will be analyzed.
And I would add that there are, centers now that are measuring levels of modulators. I don't know how that fits in, but it's also something to think of moving forward in this research is there any correlation or any benefit to getting levels? And I don't think we know yet, but there are several abstracts at this conference talking about modulator levels.
Thank you.
Dr. Ginsberg, I have a question. You mentioned designing a clinical trial in the future. How would you design that? And do you think that there is equipoise to randomize to modulator versus not?
That's a great question. And certainly in that setting, I would collaborate with experts within the field. But given that we do not have a full understanding of what the effect of CFTR modulators, we certainly have a suggestion that they're beneficial. I think a randomized control trial with placebo would be the most beneficial. And I think it's important because right now there is really not an effective treatment for acute recurrent or chronic pancreatitis. Certainly we have evidence that the use of pancreatic enzymes can decrease the frequency of acute pancreatitis, but beyond that, it's mostly mitigating the long-term sequelae and treating the pain in the moment. So I think it's really critically important for this patient population so we have another option to treat them.
There's a question from the app regarding whether any of the patients were on a reduced dose of modulators.
I don't know that information. I don't think so, but I don't know.
The next question, can we ask one more from the app? Okay. In the non-CF patients, was there any data about their genetics and other mutations associated with chronic pancreatitis? So did they have like a CFTR mutation and then a SPINK or a PRSS1?
Yes, so we did have all of that information available, and all of the 22 patients that we identified only had CFTR variants.
That was actually my exact question.
Oh.
Who the non-CF patients were. I guess I'll expand on this. Do you think that these CFTR modulators could help non-CFTR mutants or variants, so for anatomical disease or other causes of acute recurrent pancreatitis?
I think that's a fantastic question. And, there is emerging evidence that the CFTR modulators will, as we know, thin the pancreatic fluids as they're coming out. So certainly if there's some element of obstruction, it is a possibility. But I think that further research will illuminate whether they're efficacious or not.
Were there any of the non-CF patients that had non-transporter defects?
I don't believe so.
Thanks.
Thank you very much for an outstanding presentation. My question is more provocative in this case. Stephen Conkley, University of Calgary, hepatologist. In this context, with the recurrent pancreatitis, would you advocate starting this CFTR modulating therapy in patients with the recurrent episode of pancreatitis, even if there's no lung indication?
I think that's very much patient dependent. For example, you can have a patient with acute recurrent pancreatitis that has one episode a year. They're in the hospital for 2 days. They go home and their quality of life is really not severely impacted. And conversely, you can have patients with acute recurrent pancreatitis who are in the hospital once a month for a week to 2 weeks. So I think it's really looking at each of your individual patients and deciding what is going to be most beneficial, as well as taking their other comorbidities. So for example, I have one patient that we're in the process of starting CFTR modulators who has had monthly attacks that involve him being in the hospital between 10 and 21 days. And so he's now spending more time within the hospital than outside. And so certainly in that patient, it's worth, trying to see if we can improve his quality of life.
We have a question from the app, and I'm sorry if we don't get to all of them. We have about 2 minutes left. How do we reconcile this data with the observation that there are CF patients on highly effective modulator therapy with acute pancreatitis, which they developed while on highly effective modulator therapy? At least in the adult patients, I have seen a few cases who had CT imaging consistent with acute pancreatitis.
That's a really great question. And that was part of the reason we actually wanted to do this study, because we, again, saw that in pancreatic sufficient patients that this was going to decrease the episodes of acute pancreatitis, but we didn't really know what would happen with pancreatic insufficiency. And I think, with the conclusions of the study, we can say it's a mixed picture. I certainly think that a lot of patients may be developing from pancreatic insufficiency into the more moderate pancreatic insufficiency zone, and that's what's allowing them to develop acute pancreatitis. And it's really going to be evaluating what their long-term disease looks like. For example, does their pancreatic function continue to improve to the point that they get to sufficient, and then we can treat them like a typical patient and try them on modulator therapy? Do they can kind of continue to swing between insufficient, sufficient? And so just like with the question of are CFTR modulators efficacious in patients with other carriers, I think that would have to be a case-by-case basis. But certainly the evidence suggests that it can decrease it and can increase it, and so further research will be required.
There was a question about whether you measured or it was available the measurement of inflammatory markers consistent with pancreatitis, like CRP.
Yes. Yes, the CRP was available for all acute pancreatitis attacks. We did not analyze that as a measure of the acute pancreatitis episodes, though. Thank you very much.
Okay, we will invite our next speaker up to the podium. Haley Dodson is a research technician at the University of North Carolina at Chapel Hill, and she's going to present her abstract, Intestinal Complications in Cystic Fibrosis, Insights from F508 del CFTR Mice on Mucin Dynamics and Altered Cellular Functions.
Good morning. Thank you so much to the speakers for allowing me to come today and talk to everybody. This is going to be a little bit of a transition into more basic research, but hopefully I can still address some topics that are interesting to everyone in the room. And I have no disclosures. So as most of us are probably familiar, cystic fibrosis is a multi-system disease, two of the most heavily impacted being the respiratory system and the GI system. While the highly effective CFTR modulator therapies have greatly improved our respiratory symptoms, they've done very little to mitigate the GI symptoms. One of the earliest clinical manifestations of CF is the neonatal bowel obstruction, most commonly caused by Meconium ileus. Meconium is the first stool that a newborn passes after birth, and Meconium ileus is a bowel obstruction that results when that stool is too thick and adherent to pass appropriately. And this condition impacts 14 to 20% of infants with CF. Even if we don't see GI symptoms early in the life of CF patients, they can also develop them much later into their adulthood. One of the primary examples being distal intestinal obstruction syndrome, or DIOS, which impacts 16 to 20% of CF adult patients. Remarkably, the severe GI pathologies that we see in our CF patients are also witnessed in all CF animal models. In our lab, we use the F508 del CFTR mouse model, and these CF mice are maintained on an osmotic laxative from birth. However, when removed from laxative for 48 hours, they develop a bowel obstruction that typically forms in the ileum. So all the data I'm going to be showing today is from mice that have been weaned from laxative. So on the left, we have some gross anatomy images. We have our wild-type GI tract on top and the CF GI tract on the bottom. In the upper left corner is the stomach, followed by the duodenum, jejunum, ileum, cecum, and finally the colon down here in the bottom right, just to orient everyone. And then on our CF image, we can see a yellow arrow pointing to the initiation point of a severe bowel obstruction that this mouse developed in its ileum. Using ABPAS stained ileal sections from our wild-type NCF mice, we can see that the CF ileum is characterized by an accumulation of excess mucus. That was then confirmed using scanning electron microscopy images. These images have been recolorized so that the villi aren't pink and our mucus is in yellow. And we learned from this that even after persistent washings of the tissue itself, we're seeing mucus still adhering to the ileal crypts of the CF mice. We wanted to take what we know about the lungs and use that to help us hypothesize what's occurring in the gut. So we know that in healthy airways, a MUC5AC, MUC5B rich mucus layer is transporting continuously over the periciliary layer due to active cilia movement, and the periciliary layer being composed of tethered mucins 1, 4, and 16. In the CF airways, our mucus layer is hyperconcentrated, therefore compressing the PCL and prompting mucus accumulation as well as potential duct obstructions. So we believe that in the healthy intestine, a MUC2 mucus layer is flowing over the glycocalyx smoothly due to peristaltic movement. The glycocalyx is a matrix-like layer structurally similar to the PCL, but in the gut, it's composed of tethered mucins 13 and 17. So in the CF intestine, we think that our MUC2 is hyperconcentrated, compressing and penetrating that glycocalyx, causing focal adhesion of mucus as well as prompting the formation of bowel obstruction. We collected luminol content from the ileum and colon of wild-type NCF mice and performed a percent solids analysis. From this data, we saw that the percent solids observed in the CF ileum is significantly higher than what's observed in the wild-type ileum. reaching an average of about 30%, and that value is comparable to the percent solids that we find in the wild-type colon. And this is notable because the ileal epithelium is not adapted to withstand a salinity greater than 25%, meaning that this hyperconcentrated luminol content could be contributing to one of the reasons that the ileum is such a common reason or region that our bowel obstruction forms. We wanted to look at the composition of the bowel obstruction itself. So we took a CF mouse that has been removed from laxative and formed a severe obstruction and took tissue sections from different regions throughout, our distal region being at the very initiation point of the plug, while our mid and proximal regions were a little bit farther into the obstruction itself where feces has begun to accumulate. We stained sections from each of these regions for H&E ABPAS. We performed immunohistochemistry to mark DAPI and WGA lectin. WGA lectin marking the N-acetylglucosamine residues on glycoproteins as well as sialic acids. And we performed RNA in situ hybridization to mark 16S bacteria signal. So from this, we can tell that our proximal region is characterized by a thick layer of mucus surrounding the perimeter of our luminol content. That's characterized by our ABPAS and WGA stain. We also saw a co-localization of this layer with our 16S bacteria signal, indicating that the mucus may have been penetrated by the bacteria and they could have colonized the glycocalyx. However, when we move down to the distal region, which again is the very beginning of that plug, and we zoom into the plug itself, we surprisingly saw very little 16S signal. Instead, we saw an accumulation of excess mucus and a great number of H&E and DAPI marked nuclei. So from this, we believe that rather than being initiated by an overgrowth of bacteria, we think that the bowel obstruction is initiated by a accumulation of adherent mucus and accumulation of inflammatory cells that form the plug. We then looked at gene expression trends along the GI tract of wild-type mice. So we performed qPCR to look at CFTR expression and found that it was fairly uniform along the length of the GI tract. However, we saw MUC2 expression increase as we moved distally along the GI tract and peaking in the colon. We confirmed these trends using RNA in situ hybridization, where we saw the same nice slope of MUC2 increasing as we moved distally, and that's beautifully reflected in our images as well. To look at these trends in a little more detail, we broke up the signal based on villi versus crypt region. So we saw that for the duodenum, jejunum, and ileum, CFTR was significantly higher expression in the crypts when compared to the villi. We observed the same for MUC2 for all regions, and this led us to take note of a potential strong correlation between elevated CFTR and elevated MUC2 expression, specifically within the ileal crypts. So using ileal sections from our wild-type NCF mice, we performed bulk RNA-seq analysis, which allowed us to look at the expression of our mucin genes as in like a greater picture. And we can see that a lot of our mucin genes, which are on our volcano plot in green, are localized down here, indicating that there's very little variation of expression between the wild-type NCF mice. The two that are upregulated in our upper right quadrant are MUC4 and MUC3A. However, when we look at these genes on a transcript per million level, we can see that out of all our tethered mucins, MUC3A and MUC4 have the lowest expression level. They're also the structurally smallest. Instead, we took note of MUC13 and MUC17, which have extremely high expression levels, even compared to MUC2 expression, which is considered the predominant gut mucin, as well as being the structurally largest tethered mucins that compose the glycocalyx. Even though we were surprised by the lack of upregulation of mucin genes, including MUC2, we did see an upregulation of glycosyltransferase genes, which are indicated in red on our volcano plot. And this means that while mucins are not necessarily more numerous in the CF ileum, the ones that are present may be more heavily glycosylated, causing a more dense environment, compact with mucins, as well as potentially causing them to be more adhesive. So after looking at our expression data, we wanted to dive closer into the protein levels. So we performed immunohistochemistry on the ileum of wild-type NCF mice, looking specifically for MUC2 and WGA lectin. And we can see that there's a clear excess of both MUC2 and WGA in the CF ileum. When we zoom in closer, we can see that a lot of that signal is localized to the CF ileal crypts specifically, indicating that our crypts are densely packed with not only core MUC2 protein, as well as the oligosaccharides and glycoproteins that are indicated by WGA. And we quantified this by looking at percent signal specifically in the crypt region and saw it significantly elevated for our CF mice when compared to wild types. We think that this compaction and high mucin presence in the ileal crypts could be impacting the functions of other cell types, one of those being panacells. So panacells are specifically localized to the crypts of the ileum and are responsible for stimulating immune responses and regulating the stem cell niche environment. Using H&E staining, which marks the eosinophilic granules produced by the panacells in pink, and IHC for lysozyme, which is another panacell product. We looked at the different distributions between the wild-type NCF mice, and our wild-type crypts are characterized by a dense population, heavily compacted with both eosinophilic granules, as well as a nice dense signal of lysozyme product, where our CF ileal crypts appear more empty. The eosinophilic granules are not as compact with one another in the crypts, as well as our lysozyme signaling appears much more sporadic within each crypt. These trends were also reflected on a genetic level, where we have our lysozyme gene as well as numerous defensine genes being downregulated in our CF mice. And this impaired function of panacells may result in dysbiosis, chronic inflammation, and impaired tissue repair, which are some of the things that we know characterize the CF intestine. Finally, using our bulk-seq data, we performed a gene set enrichment analysis, specifically looking at hallmark gene set pathways. So here I have a list of some of these significantly upregulated pathways that we saw, and I'm going to touch on just a couple of them. The first being hypoxia. An upregulated hypoxia pathway can result in a few things, including a compromised gut barrier function, impaired cell turnover, as well as dysbiosis. We saw an upregulated inflammatory response pathway, not only genetically, but also using inflammatory cell markers such as the CD45, which marks lymphocytes, and we saw that being elevated in the ileum of our CF mice when compared to wild types. Implications of this include chronic inflammation and a damaged epithelial lining. Finally, we saw an upregulation of P53 pathway, which may result in dysregulated cell proliferation and increased cancer risk, in this case being an increased risk of developing colorectal cancer. We also saw some significantly downregulated hallmark pathways, including fatty acid metabolism, which may result in malabsorption, as well as a reduced transportation of fat into the bloodstream. And finally, we saw a downregulation of oxidative phosphorylation, potentially causing low ATP, which may result in reduced gut motility, as well as reduced gut cell proliferation and differentiation, and dysfunctional mitochondria. So just to cover some of the many conclusions that we touched on, we observed an accumulation of hyperconcentrated mucus and inflammatory cells that we believe initiates the bowel obstruction or the ileal plug rather than an overgrowth of bacteria. While we were surprised by no difference in MUC2 mRNA expression in the ileum of our wild-type NCF mice, we did see an accumulation of MUC2 protein that occurred specifically within the ileal crypts. That occurred along with an elevated glycoprotein level and an elevation in glycosyltransferase gene expression. We think that these densely packed crypts may be resulting in dysfunctional panacells that would be responsible for the dysbiosis and chronic inflammation observed in CF. We saw multiple hallmark gene pathways altered, some of them being an upregulated hypoxia pathway, inflammation pathway, and tumorigenesis pathway, as well as a downregulated fatty acid oxidation and oxidative phosphorylation pathways. And finally, our results suggest that an altered P53 pathway may be increasing the risk of colorectal cancer development in CF patients. And I just want to thank everybody from my lab, especially Camille Ayer, who has been so supportive for me in this project and getting me here to this conference and putting together this whole presentation. I wouldn't have done it without her, as well as our numerous collaborators at UNC and our funding sources.
Very nice work, Zach Sellers. First off, I want to congratulate you. I mean, I know it's easy for us to say, just do RNA sequencing, just do in situ hybridization. It's a lot of work to do these experiments, and the analysis takes a lot of time, so I just want to point that out to everyone. My question for you is, if I understood correctly, you, in those RNA sequencing studies that you compared the ileum at the site of the plug, the distal part between wild type and CF. Did you also do RNA sequencing and similar type of analyses in situ hybridization on those mid and proximal sections, and then compare what the sequencing profiles and sort of the general signals were across the proximal, mid to distal, since your phenotype is different in sort of a way to see, can you, even though it's at the same time period, can you use this almost as a sort of a sequence of events of how these changes may occur?
We did not. I think that would be something interesting, especially for the inflammatory response pathways. We did not, though. And I think that it might be a little bit harder because of the fecal accumulation and bacteria overgrowth that happens in more of that proximal section, decreases the quality of our mRNA samples. And I wonder if that could potentially skew the data in one way or another. But I think if there was a good way to do that, it would be something really interesting to look at.
Yeah, maybe a way to get around, I mean, you could do different time points, right, before obstructions, but yeah, something technically maybe to think about. It may give some insights.
Thank you.
Really fantastic work, really, really wonderful. I just wanted to ask, with all these changes, whether they're really CF related. In other words, if you take a group of mice and you do ileal atresia or something, or you cause some other obstruction, and whether you looked at all these other changes, whether they're secondary to that.
I think that's a good question. I know our long-term plan would be to have this data come from mice that are both on and off laxative. So obviously off laxative, they would have a bowel obstruction, and we would hopefully see similar data to what we have now. And then if we have them off the laxative, they would not have a bowel obstruction, since that they're able to pass appropriately, and maybe that could reveal if some of the genetic pathways that we're seeing are resulting from truly the CF phenotype of CFTR dysfunction, or if it's stimulated by the presence of the bowel obstruction.
Hi, Michael Hook from Children's Los Angeles. Wonderful presentation. I appreciate it. My question was if there was any histologic evaluation of the muscular layer, both in the distal ileum and more proximal parts of the small bowel, and if there's any ability in this mouse model to measure motility in the distal small bowel, thinking about the thickness of these mucus layers and how they might impact the motility to produce DOs.
Yeah, we have not measured muscular layer necessarily. I know that there are some good histological sections that we've taken note of potential increased muscular layer in CF, but we haven't quantified where I feel confident to say yes or no, there is a particular result. As for motility, that's a great question. I'm not exactly sure. I don't know that I am qualified on the GI tract enough to give you the best answer possible, but I think that's a good thing to look at.
Great talk. Alvin from UCLA Pete's GI. I have two questions. One should be pretty quick. I'm curious whether in your model, if you ever tried doing a rescue experiment where you give back a laxative and see if you could just reverse everything that you had just seen. That would be my first question. And then my second one is, I think on your previous slide, you had showed that bile acid metabolism was the most downregulated. I'm curious if you had looked at bile acids in this region And partially I ask that because there are specific bile acids that are more mucin depleting. So I'm curious what your thoughts are as a potential therapeutic, whether you could use specific bile acids to deplete the accumulation of the mucin.
Good questions. No, we have not necessarily tried to do a rescue experiment, just because sometimes with the mice, it's a little bit hard to predict the severity of the bowel obstruction. So it would be interesting to try to time the administration of the rescue, like if it's soon enough that it would be able to mitigate the already existing impacts of an obstruction. However, I think it would be something interesting since these mice aren't impacted by ETI. I think it would be good to look at a different rescue method to see if, the genetic pathways are restored back to what we see in our wild type mice. As for the bile acid pathway, we haven't necessarily explored that one so much. I know that there are some specific receptors for bile acids that have been impacted. I don't feel comfortable naming a few off the top of my head, just because that's not my area of expertise or something that I've spent enough dedicated time looking at. But I think that in the future we would like to do some type of profile to see the bile acids present in the luminol content of wild type and CF mice.
Thanks.
We have a question from the app. How does the hypothesis emphasizing the role of dysbiosis apply to understanding the mechanism of meconium ileus in sterile newborns?
I'm sorry, can you repeat the question?
How does the hypothesis emphasizing the role of dysbiosis apply to understanding the mechanism of meconium ileus in sterile newborns?
Okay, so for dysbiosis with an overgrowth of bacteria that we saw colocalizing with our mucus layer, if it's been penetrated and impacted by a colony of bacteria, they can get stuck together, adhering with the excess mucins or the heavily glycosylated mucins, prompting that adherence of the meconium stool.
I do have a question. Do you think you would try, I don't know if this is feasible, treating the mice with a modulator and see what happens to some of your endpoints?
They don't restore with an ETI modulator. But there is humanized mouse models that we're looking into getting that do respond to that. So I think it would be interesting to use what we've learned here and kind of apply that information to the humanized mouse models that we can restore.
Thank you.
Thank you.
All right, we'll invite our next speaker to the podium. Dr. Nicole Green is Assistant Professor of Pediatric Gastroenterology at Seattle Children's Hospital, and she'll be presenting her abstract, Frequency of Hepatobiliary Abnormalities in Young Children with CF Before and After 6 months of elucidating, tezacaftor, ivacaftor, Results from the BEGIN study.
Good morning, and thank you to Dr. Sathi and Dr. Cummings for inviting me to speak today. So as the title suggests, we've moving to the liver. And again, this is the results from BEGIN. So I am presenting today on behalf of the BEGIN PIs and investigators. I have no relationships to disclose related to this presentation. So little is known about the frequency of CF hepatobiliary involvement in young children with CF. We do know that advanced cystic fibrosis liver disease occurs in up to 10% of children with CF, and it typically occurs early in life by the first decade. It is unknown if elexacaftor, tezacaftor, ivacaftor, or ETI will improve or alter the natural history of advanced CF liver disease in children with CF, but it is known to cause some drug-induced hepatitis. So BEGIN is a prospective study to evaluate the biological and clinical effects of significantly corrected CFTR function in infants and young children. It is a two-part, multi-center prospective observational study of young children, so aged 2 to 5 years old, before and after initiating ETI. So part A is a natural history study. So it's prospective, cross-sequential, looking at growth, GI health, and pulmonary function in infants and young children with CF. So this group is essentially modulator naive, or at least has no history of prolonged use, defined as greater than 6 months, of ivacaftor or ETI, and had not used modulator within the past 28 days. And then part B of the study is a longitudinal study to observe the effects of ivacaftor or ETI. And again, describing changes in growth, GI health, and pulmonary function following initiation of these modulators in infants and young children. So a quick visit overview schematic. So part A, that natural history, we have baseline data, and then following 3, 6, 12, 24, and 36 month, with also some extended enrollment period. And part B is the pre-post modulator part of the study. So baseline, pre-ETI start, and then we have data at 1, 3, 6, 12, and 24 months, as well as an extended enrollment. For the purposes of this study, I will be focusing on the 6-month data as well as some 12-month data. So this talk is focused on the hepatobiliary outcomes. So we assess this through labs and biomarkers, as well as liver stiffness measurements. So in terms of the liver labs, we have AST, ALT, GGT, and direct bilirubin. And we defined abnormal based on the upper limits of normal for pediatrics. So those upper limits of normal are displayed in the table on the right. For APRI or AST to platelet ratio and GGT to platelet ratio, so these are biomarkers of liver fibrosis, we used thresholds based on some liver biopsy validated thresholds for CF children. So an APRI greater than 0.264 was considered abnormal, as well as a GPR greater than 0.2. And we have these values collected at baseline, 3 and 6 month and 12 month post-ETI. For liver stiffness, we have baseline and 12 month data, and that was assessed based on transient elastography. A quick note about the statistical analysis. These outcomes were analyzed using Bayesian generalized linear mixed models appropriate for each data type. So logistic regression for binary outcomes and gamma regression models for continuous positive outcomes. And I will note that this is still preliminary data, so there is some data cleaning that still needs to be done. So keep that in mind when looking at the following results. This table is just displaying the demographic and baseline characteristics of the children enrolled in Part A and Part B. So a relatively even distribution in terms of sex, age. So mean age in Begin Part A was about 3 years and 4 years in Part B. Over 90% were white, about 60% were Delta F508 homozygous, and the majority were exocrine pancreatic insufficient in both studies. So this first part is asking the question of what might we expect to see in the absence of any modulator in terms of natural history. So would we expect changes in labs? We have 1.7 years of data between Begin Part A and Part B baseline data. And while it looks like there might be statistical significant decrease in AST, when you actually look at the modeled means, it's not clinically significant. So really no change in the absence in those period of childhood that we could detect in the study. So what about after initiation of ETI? So this is after 6 months of ETI, looking at percentage change in these labs. Again, while it looks like there's some statistical significance in some of these labs, when you actually look at the values, there really is no clinically meaningful change after 6 months of ETI. So then we ask the question, what about children who had abnormal labs at baseline? So we defined abnormal as 1.5 times the upper limit of normal for those pediatric thresholds for these respective labs. And can we see a decrease in the proportion of children who had abnormalities in one of these lab values? So the farthest two left points for each graph are the baseline data from Part A and Part B. And then as we move to the right, we have 3-month data and 6-month data. So just looking as an overview, it does seem like there is a decrease in the proportion of children who had abnormal AST and ALT after 6 months of ETI. So for example, with ALT, you went down from a 30% or 26% abnormality at baseline Part B to 15% after 6 months of ETI. This forest plot is just demonstrating that same data in a different way. So it does seem that there is a significant decrease in the proportion of children with abnormal AST and ALT. Next, I just have some swarm plots to demonstrate this data. So each dot is an individual child's labs at the various time points, with red being greater than 1.5 times the upper limit of normal. So as you can see, there does seem to be a decrease in the number of red dots over the 6-month period. Same with ALT, but really not much change in direct bilirubin or GGT. For platelets, we colored red those who had a value less than 150, and really no notable change, with only 3 dots abnormal at baseline based on that definition. So then we decided to turn to the biomarkers of liver fibrosis. These are thought to be more specific than liver labs alone for and a non-invasive method for detecting advanced fibrosis and portal hypertension. There should note that there are a few biopsy-validated studies in CF defining specific thresholds, but a quick note to orient everyone in terms of APRI and GPR. So APRI is AST to platelet ratio, GPR, GGT to platelet ratio. So as you can see, as your AST or GGT increase, your APRI or GPR will go up, and equally with your platelet count decreasing, your APRI and GPR will also increase. So again, these we used some previously cited biopsy-validated thresholds for APRI and GPR as indicating increased risk of CFLD. So APRI greater than 0.264 and GPR greater than 0.2. Looking at the table, so the baseline to the 6 month data, there really isn't a significant change in the percentage of children who had abnormal APRI or GPR at the 6 month time point. Obviously, 6 months is not that long to detect change. But what I find most striking is the baseline data, actually, with 67% of children having what we would think of as an increased APRI, indicating an increased risk of CF liver disease. And it may be that these thresholds just need to be studied more closely in this younger age group. These are, again, just swarm plots with the red indicating abnormal values, just demonstrating that there does not seem to be a significant change over the 6 month period in the proportion of children with abnormal values. Finally, we looked at liver stiffness assessed with transient elastography, and we used thresholds defined in the recent CF liver consensus recommendations as greater than 5.95 kilopascals being associated with CF-associated hepatobiliary involvement, and greater than 8.7 for indicating advanced CF liver disease, or F3 to F4 liver fibrosis. Looking at the baseline data, so and then change at 12. So we only have the 12-month for liver stiffness. But you can see the percentages there are the percentages of children who had abnormal values, either greater than 5.95 or greater than 8.7. And there isn't much change after 12 months. Again, we have wide confidence intervals, so take that with a grain of salt. But again, I think what is most interesting or surprising perhaps is the baseline data with 20 to 37% having increased liver stiffness associated with CF-associated hepatobiliary involvement, or 8 to 9% associated with more advanced liver disease in this young age group at baseline, so pre-ETI. To conclude, at baseline of the 191 children with CF, 27, 46, 7, and 5% had abnormal ALT, AST, direct bili, and GGT respectively. And then, of course, we define that as 1.5 times the upper limit of normal for those pediatric labs. After 6 months of ETI, the proportion of children with CF who had abnormal ALT and AST was lower at 15 and 35% respectively, but we did not appreciate a change in proportion of children with CF with abnormal GGT or direct bili. At least we can say that it seems like there are no early signs that ETI is hepatotoxic in young children with CF after 6 months. Surprisingly, 67% and 7% had abnormal APRI and GPR respectively at baseline, and that there was no notable changes in these proportions of abnormal APRI and GPR after 6 months of ETI. 20 to 37% had liver stiffness concerning for CF-associated hepatobiliary involvement, and 8 to 9% had liver stiffness concerning for F3 fibrosis at baseline. But we did not see a change in the median liver stiffness after just 12 months of ETI. Lots of people to acknowledge the BEGIN study collaborators and principal investigators, the TDNCC study team. I would like to give a special call out to Colin O'Rourke, who did a lot of the statistical analysis and made those figures for this presentation, and Daniel Lung, who also helped with this presentation, funding from the Cystic Fibrosis Foundation, and of course the participating patients and their families. And with that, I'm happy to take questions.
Nicole, very good job for presenting this data. I think it's the more data that we have in these different cohorts really is giving us insight into what may be or may not be happening, and certainly ages of individuals and their sort of starting points of what kind of liver involvement they have or not is going to influence that. I guess one point of caution as we look especially at the liver fibrosis indices, the APRI and GPR, specifically as we investigate pre and post ETI. I know you showed that there was not a clinically significant change in platelets, although it did decrease quantitatively at least a little bit. Since platelets is used in the denominator of those fibrosis indices, changes in platelets alone can influence those indices. And I know it's been shown by ourselves and other groups as well that ETI, maybe more in older individuals, can decrease the platelets from more of a relative thrombocytosis to maybe more of a normalization, which can then actually make your fibrosis indices go up.
Yeah.
Even though, because the platelets are coming down, even though it's really a normalization. So I guess as I look at your data with those, I guess we have to wonder how much of a confounder that could be as to not being able to see a difference. And I guess just a word of caution to us all in an area that we really didn't have to think about in other modulators, I think.
Yeah, definitely. Great point. Yeah. So I think we need to think about those thresholds and biomarkers for sure in all the age groups, but particularly this one.
Cole, I have a practical question, which is, this is a challenging age actually to get a good fiber scan in. In the results that you're collecting, was there any reflection of like how many had consistent fiber scans? Because I know from time to time at my center, sometimes it's dependent on how irritable the toddler's being that day and how good the tech is that day to whether I'm going to get good numbers. So, I mean, did you guys have like good consistency in the measurements from within each patient?
Yeah, so as part of the data cleaning, they are looking at sort of consistency. And for this, yes, we used that. And that's why also our numbers are smaller, as you can see, than the overall population, just in terms of those which we had good FibroScan data for. Yeah. that definitely comes into it.
Well, if there aren't any other questions, thank you, Nicole. We'll go to our last speaker. And so Dr. Michael Narkowitz is a professor at the University of Colorado. He's a pediatric gastroenterologist, and he will be presenting PROMISE data. So his abstract is entitled Elexacaftor, Tezacaftor, and Ivacaftor do not improve indices of hepatic fibrosis, liver stiffness, or hepatic steatosis after 3 years, interim results of the PROMISE study.
Thank you. Thank you for the moderators for choosing this. And I'm representing the full PROMISE study for this. I do have some relevant disclosures to this, and they're listed there. You've heard this background already. Nicole set the stage for this. So we know that ETI has had really remarkable life-changing effect on pulmonary nutritional outcomes. However, it's really unclear if it has any impact on hepatic outcomes. You can tell from my title sort of what I think, but it remains unclear. So PROMISE is and was a prospective longitudinal study to evaluate both the biological and clinical effects of significantly corrected CFTR function. It was the first longitudinal study of a new modulator that chose to look outside of the classic pulmonary nutritional outcomes. And as part of that, we were invited to develop a liver sub-study, which was embedded within PROMISE. And this embedded liver sub-study, there are many others, you heard about GI and others, sought to evaluate the impact of ETI on liver outcomes. So we had major aim, which was to prospectively investigate the impact of ETI on liver enzymes, fibrosis indices, which Nicole set the stage for, liver stiffness, and steatosis, which is fat accumulation in the liver. Our primary hypothesis was that this treatment would lead to improvement in liver fibrosis indices and liver stiffness. And our secondary hypothesis, based on some case studies, was that ETI treatment would improve hepatic steatosis when it was present. So this, much like BEGIN, is a prospective observational study of people with CF who were 12 or older. It started in 2019. We do remember what happened right after that with it. And they were planning to start ETI. Sub-study of liver stiffness and steatosis used vibration-controlled elastography, VCTE is what I will call it, at centers that had the equipment. We used one manufacturer, one piece of equipment, because the values, depending on the methodology you use, are incredibly variable and are not able to be compared between devices. For all subjects enrolled in PROMISE, we classified their CF hepatobiliary involvement by standard data form that looked for historical data and underwent central review. So somewhat similar, if you're familiar with the Irish study, it's a similar methodology. We classified individuals who were participating in the study as those with no clinical evidence of CF hepatobiliary involvement. You can see the abbreviation. Those who had involvement but no evidence of cirrhosis or portal hypertension, so that's just CF hepatobiliary involvement, and those with advanced involvement with portal hypertension or cirrhosis, using the new terminology, advanced CF hepatobiliary involvement. Liver enzymes, platelet count, and liver fibrosis indices were calculated on all. We used standardized upper limit of normal, similar to the method that was just shown. We added another fibrosis marker, which is called the Fibrosis 4 index, and that, of all the markers, uses ALT also. The elastography sub-study was performed at centers who had the ability to perform annual VCTE using FibroScan technology. Last time I'll use that word. we determined liver stiffness as an indirect measure of liver fibrosis. Just to comment, liver stiffness measures the speed at which a transmitted sound wave moves through the liver. As the sound wave moves faster, the liver is stiffer. It is correlated with fibrosis, but there are other entities that can increase liver stiffness. If you have significant hepatic inflammation, if you have hepatic congestion, if you have just eaten, your portal vein flow goes up and your liver becomes stiffer. So that's why I call it an indirect and maybe an imperfect measure of fibrosis, which is why we didn't classify based on fibrosis. We also utilize continuous attenuation parameter, which is a qualitative measure of hepatic steatosis from none, mild, moderate, or severe. Statistics are fairly straightforward, except that the comparisons among these groups were either by generalized linear mixed models with either normal or binary outcome, and we incorporated random subject effect. So here is the enrolled cohort. So there were 464 individuals who enrolled. Among those individuals, roughly 3% had advanced liver disease. 50% had some evidence of CF hepatobiliary involvement, and roughly the same number with no hepatobiliary involvement. You can see this is very different from the BEGIN study, average age 26, and about a third were less than 18, a third were 18 to 30, and about a third were older than that with it. It represented mainly a Caucasian population, I would say, looking at this data. There were no differences in genotypes, prior modulator use, rate, or ethnicity between these three groups. So key baseline data shown as median and IQR. You can see that basically across the board in the all group, they had normal liver enzyme as the median and pretty close to it, normal platelets, and had these baseline fibrosis indices. As would be expected, those with advanced CF hepatobiliary disease had lower platelets, they had higher liver enzymes, and they had higher fibrosis indices. So it goes along with that group being well classified. So what happened over time? So this is similar to another graph I'll show you. You have the different groups with advanced liver disease on the left, liver involvement in the middle, and no liver involvement on the right. Prior modulator use is shown in red, and those who had it are in red. Those who did not use modulators before are shown in green. The trend line is shown in green, and these are individual plot data for everyone. And what it really shows is that over the course of the 3 years of the study, so visit number 5 is year 3, there are no population-based statistically significant differences in APRI in the group over time. And unfortunately, that is true in GGT to platelet ratio also. It looks like it's a downward trend in the advanced, but the numbers are very small in that space. So, summary for the group: no changes in enzymes over time, no changes in platelets, no changes in fibrosis indices in almost 425 individuals over 3 years on ETI. No change. So what about other markers? So elastography is a method that I discussed, and you can see that we had variable numbers of individuals at each time point. We had 174 enter, and then people got various elastography values. I would say the COVID pandemic did not help this because people were not very interested in coming into clinic, particularly in the first year over time. But what you can see, so KPA is a measure of liver stiffness. It was in the range for adults, which is basically normal as the mean value. For those, I'm I'm a pragmatist. I use simple numbers for values. So for those with a KPA above 10, there's no doubt that those individuals have advanced liver stiffness, likely fibrosis. You can see that there's some change in the numbers, but when I show you people who had it, this assessed every year as a group, there are no differences among the groups. So CAP, or continuous attenuous parameter, is a measure of steatosis. Values above 240 or so are beginning of steatosis. There was no significant change over time, and there was no increase or decrease in the frequency of those with severe steatosis. Well, that first table doesn't really help you much because you have different numbers of people. So this table represents the 73 subjects who graciously had 4 elastographies performed over the course of the study. And you can see that over time, there is no change in their liver stiffness, shown by KPA. There is no change in the percentage of those with severe fibrosis. And unfortunately, there's no change in those who had normalization of their liver stiffness. So the conclusions are relatively straightforward. Over 3 years of ETI treatment, there is no evidence for improvement in hepatic fibrosis indices as a group, or in those that either had liver involvement or advanced liver involvement. This is also shown in a smaller cohort with no change in liver stiffness over time and no change in the number of individuals who had severe hepatic fibrosis. There's also no change in hepatic steatosis. So while I think longer-term studies and studies in young children with CF are needed to determine if ETI can prevent advanced CF-associated hepatobiliary injury and involvement, there's no evidence to date that at least the duration of therapy we have has been effective at this. And with that, I'm happy to take questions.
Mike, I had a question about whether you guys correlated the CAP with BMI and if you saw any difference in hepatic steatosis in regards to increases in BMI.
Yeah, we haven't done that yet, Meg. Okay. We have one more round of elastography to go, and we also have one more parameter that we looked at for improvement in liver function, which is really bile acid metabolism, that the results just were done like 2 weeks ago, so we haven't done that analysis.
Go ahead.
Hi, Mike. Great talk, Michael. Paul McNally from Dublin. So we are running a similar longer-term study with smaller numbers of patients, and not to ruin the surprise for tomorrow, but our data doesn't look that different to yours. I'm very interested, though, as you allude to in the end, it may not be, do we see any change, but the bigger question is, can we prevent it over time? So high numbers, longitudinal analysis. And it's great to see BEGIN, and we have a similar study, ENHANCE, in Europe that'll be looking at that. What do you think are the most sensitive? If we were to do that, we have a lot of subjects, probably 1,000 subjects between the two studies. What are the most sensitive endpoints that we should be using?
Yeah.
Or is it as simple as, do you or do you not have advanced CF liver disease?
Yeah. So I think the question really goes to, is there a biomarker that can predict the development of advanced liver disease, and can it improve? To date, I think the best marker is GGT to platelet ratio to date, as that seems to be correlated with subsequent development in some other studies, and that it's an earlier biomarker, and it makes some physiologic sense based on some other items. But I do think the short answer is, it's as simple as, did we reduce the frequency of advanced liver disease or not? The problem with that study is it's a 10-year study, and if the prevalence is 7%, we did the math once in the US, we'd have to enroll every person in the US in a study to see a 50% reduction. That's the challenge. But if we start in young kids, and at age 15, the prevalence of advanced liver disease with all of our new guidelines and screening, which will increase probably detection, if that's significantly lower, then that's probably the best outcome. That's
Great.
what we want to do.
Thank you.
And I would say, Paul, we have another poster, 605, I think it is, that looked at longitudinal data in our push cohort. And we did actually see what appears to be a true trend in change in the rate of increase in GGT to platelet ratio with therapies, but we had much longer lead-in. That's the other problem with this study. We don't have a lot of lead-in data to know what people's trajectory was. So it could be, the other thing we could hope for is that we slow progression of disease, but we don't have good markers for. Michael.
Great talk, great study. Bit disappointing, of course. So I think,
for me too,
don't give up. And I think we have to take a step back and look back at what actually we're looking at. First of all, the age of these patients. The liver disease starts in young age. You've got adults here. If you want to really see some changes, that's the first thing. But I think also, maybe look at something that's hepatobiliary. So maybe go to the Dutch studies looking at markers of bile acid transport.
We are.
And seeing, right, right, okay, so you're doing that. I mean, it's not necessarily these particular methods which are telling us about liver disease.
Yeah. My only comment about the adult part is there does appear to be a second peak of liver disease in adults. I know that that's controversial, and the Irish study hasn't really confirmed that, just to be clear, but in the US there does. So there may still be a preventative approach for adults who will benefit from this therapy in preventing later onset liver disease.
Great talk. Thanks, Jonathan Raymond from Vancouver. Kind of already talked about it a little bit, but why is sort of why don't you think there was improvement? Is it that, is this sort of the hepatic equivalent of irreversible bronchiectasis, right? That it's just started too late? Or is it that kind of what you were talking about now? Is it that the markers that you're using are maybe the wrong markers to look at disease modification?
So I don't think it's either one of those, actually. I think the mechanism that we put forward for liver disease in CF is wrong. This is not primarily related to a defect in CFTR causing obstructive biliary tract disease and injury. This is probably a vasculopathy. This is not probably. This is a vasculopathy, and it's probably related to gut dysbiosis and gut integrity. And so I think this is further evidence that that's not the mechanism of the disease. So correcting CFTR function in the biliary tree is not going to solve this issue. And the majority of these individuals don't have end-stage disease, so that's advanced CF disease.
Can I ask the obvious follow-up question? Then what is the intervention that you think might help with that? And then I'm going to walk away from the microphone.
I have some ideas, but I'm not going to state them publicly. I'll put it that way.
Before we ask the question from this, a follow-up to that, but the fact that we didn't see an increase, so it was stable, right? So we have to follow it longer out, but isn't there a chance that we are, maybe by what you're saying, with being a vasculopathy, by decreasing whole body inflammation and pulmonary exacerbations, maybe we're going to keep the liver disease stable?
Yeah. So there is some data that precedes modulator therapy that's suggested in CF, which is also true in non-CF individuals, that there is actually a gradual increase in liver stiffness, Meg. And one of the hypotheses was that we would change the rate. The problem is, and this gets to the tool elastography has a wide coefficient of variation, which means same test done consecutively 3 days on an individual can range very wildly, and particularly at the high values with it. So I don't know that we have sensitive enough tools yet, to your question, to actually see if we've changed that. But if it stays flat over time, that might actually be a marker of improvement. But that's where we don't have value ahead of time to know where they're going.
We have a question from the app saying, thanks for the interesting data. Are their findings adequate to guide the frequency of monitoring elastography?
Oh, so they're asking me a question about the guidelines we did. So not from this, but from other data that we have, and you can look at the push abstract and some other things. It does appear that annual is a reasonable approach, and that takes into account the variability of the test and trending it over time. Single point change over time doesn't mean that much, but if it trends over time, and you have to get enough numbers to dampen the coefficient of variation, which is why we recommended annual for individuals who have evidence of CF liver involvement.
Are there other genetic markers other than CFTR mutations that predispose to liver disease? And if so, knowing that could help us prevent progression?
There are other genetic markers. A large GWAS study that's been presented here showed carrier state for alpha-1 antitrypsin C allele is associated with it. There's also a couple of evolving more pathway markers looking at clotting and other abnormalities. To date, there's no effective therapy for being a heterozygote for an alpha-1 antitrypsin Z allele. There may be for some of the other clotting abnormalities.
Thank you, everyone, for coming to the session and being flexible with moving floors.